Lower extremity patterns are essential for treating dysfunctions in the pelvis and legs caused by muscle weakness, incoordination, and joint restrictions. These patterns are used to improve walking, stair climbing, rolling, and bed mobility, and can also be used to exercise the trunk. Resistance applied to strong leg muscles can help activate weaker muscles elsewhere in the body. The lower extremity moves in two main diagonal patterns: flexion, abduction, internal rotation with extension, adduction, external rotation, and flexion, adduction, external rotation with extension, abduction, internal rotation. The hip and ankle foot complex work together in these patterns, while the knee can flex, extend, or remain still. Proper timing starts with movement at the toes, foot, and ankle, followed by the other joints. Proper positioning is crucial for effective lower extremity pattern exercises. The patient should be close to the edge of the table with a neutral spine. The therapist stands aligned with a diagonal motion, using specific grips and resistance techniques. Grips should avoid causing pain, and resistance is applied in an arc toward the starting position. Traction and approximation are used to stabilize the limb during movement. Normal timing in lower extremity patterns starts with movement at the foot and ankle, followed by the hip and knee. Emphasis can be placed on specific components using techniques like repeated stretch and combination of isotonics. Stretch is used only when necessary to facilitate movement, starting with elongation of the distal component. Strong leg patterns can cause irradiation, activating muscles in other parts of the body. The patient's position and the amount of resistance control the level of irradiation, which can be used to strengthen, mobilize, or relax muscle chains, or to facilitate functional activities like rolling. This pattern involves hip flexion, abduction, and internal rotation, with the knee extended and the ankle dorsiflexed and everted. Key muscles include the tensor fascia lata, rectus femoris, and gluteus medius. The therapist uses specific grips and traction to guide the motion, ensuring proper elongation and rotation throughout. In this variation, the hip flexes, abducts, and internally rotates while the knee also flexes. The therapist maintains the same grips and uses traction to facilitate knee flexion. The movement ends with the heel close to the lateral border of the buttock and the knee and heel aligned with the shoulder. This pattern combines hip flexion, abduction, and internal rotation with knee extension. The therapist uses traction and specific grips, ensuring the hip and knee reach their end ranges together. The movement ends with a straight leg, and proper elongation and rotation are necessary for effective motion. This pattern involves hip extension, adduction, and external rotation, with the knee extended and the ankle plantar flexed and inverted. Key muscles include adductor magnus, gluteus maximus, and hamstrings. The therapist applies resistance and approximation, ensuring the thigh crosses midline and the lumbar spine remains neutral. This variation adds knee flexion to the extension, adduction, external rotation pattern. The therapist uses the same grips and body mechanics, applying resistance to both hip and knee motions. The movement ends with the hip extended, knee flexed, and foot plantar flexed and inverted. This pattern features hip flexion, adduction, and external rotation, with the knee extended and the ankle dorsiflexed and inverted. Key muscles include psoas major, iliacus, and adductor muscles. The therapist uses specific grips and traction, ensuring the movement is smooth and the trunk flexes to the right. This variation combines hip flexion, adduction, and external rotation with knee flexion. The therapist maintains the same grips, ensuring the knee flexes smoothly as the hip flexes. The movement ends with the heel and knee aligned with the shoulder. This pattern combines hip flexion, adduction, and external rotation with knee extension. The therapist uses traction and resistance, ensuring the hip and knee reach their end ranges together. The end position is a straight leg with adduction and external rotation. This pattern involves hip extension, abduction, and internal rotation, with the knee extended and the ankle plantar flexed and everted. Key muscles include gluteus medius and gluteus maximus. The therapist applies resistance and approximation, ensuring the lumbar spine remains neutral. This variation adds knee flexion to the extension, abduction, internal rotation pattern. The therapist maintains the same grips and body mechanics, applying resistance to both hip and knee motions. The movement ends with the hip extended, knee flexed, and foot plantar flexed and everted. Exercising both legs simultaneously increases the demand on trunk muscles. Bilateral leg patterns can be symmetrical or asymmetrical and are performed in various positions such as supine, prone, and sitting. These patterns can use irradiation from the stronger leg to facilitate weaker muscles in the other leg. Exercising the patient in various positions, sitting, prone, side-lying, and quadruped offers unique advantages and challenges. Each position affects gravity, muscle stretch, and stability differently. Choose the position that best suits the patient's abilities and treatment goals. In the sitting position, patients can see their legs and work on balance. Prone position allows hip extension against gravity. Side-lying emphasizes abductor and adductor muscles, while quadruped requires trunk stabilization and weight-bearing on arms and the non-moving leg. Each position can be adapted for specific therapeutic goals.